Perfect. Hello, guys. I am Martin Barna, online nutrition and fitness, and I will be your host for this podcast. Later, the recording will be released on my Spotify, YouTube, and Facebook. You can find all the links on web martinbarna.cz. Many thanks to the Institute of Modern Nutrition, Lucas and Miloslav, for their cooperation and shared enthusiasm for spreading science-based information from the best in the world. Our honorable guest today is Dr. Karl Nadolsky. Karl Nadolsky is an endocrinology physician, internal medicine and obesity medicine specialist. Hello, Dr. Nadolsky.
Hey, how you doing? Thanks for having me.
I'm doing great. Thank you for accepting my invitation again.
Yeah.
We talked last year. Look, as your time is limited, I would go straight to the questions if you don't mind.
Go for it, man.
Okay, Doc. First question. We are not surprised that everyone speaks about steroids, and we would like to know steroid side effects and explained the medical use against or versus bodybuilding use, and the dangers of it.
Yeah, so the basis, you're talking about anabolic androgenic steroids, AAS, that's that term. And so the basics of it are it's using testosterone medications above and beyond what your normal body's physiology desires. So we get referred patients who either are being evaluated for or maybe already diagnosed with hypogonadism or true low testosterone in men. And that can either be from some sort of hypothalamic or pituitary issue, because the pituitary is what signals the testicles to make sperm and testosterone, which we need in guys for the androgenic things like the hair growth where we want, the muscle building, also our libido, sexual thoughts, desires, and fertility, making sperm. And so, true hypogonadism can either be central, like I said, hypothalamic pituitary disease of some sort, or testicular, that's called primary hypogonadism. And then there are all sorts of other factors that can sort of cause a sort of functional hypogonadism, which can have the underlying cause treated and fixed. Like we see a lot of obesity, diabetes, sleep apnea, and sometimes medications can cause the whole thing just to not work well. And then we can treat those things without having to give other medication. We see a lot of people with pituitary tumors and surgeries, and they often need real testosterone replacement therapy. So when people see TRT, and people use that term all the time, not that many people should really need testosterone replacement therapy, because it really should be based upon a true diagnosis of hypogonadism, and that's in the context of not being able to maybe treat the underlying root cause of it, which we often try to do. So anabolic androgenic steroids are essentially using types of androgens, those testosterones, oftentimes the types of hormones like bioidentical type hormones will give to men for true testosterone replacement therapy, but they're generally supraphysiologic, meaning they're above and beyond what our normal physiology should be. And then there are, of course, risks. Obviously, it helps the professional bodybuilders build muscles beyond what normally would be able to be done with their own regular genetics and normal levels of testosterone. But there are certainly risks. Obvious side effects include infertility, shrinkage of your testicles, and it certainly makes your own body not be able to use or make testosterone. So it shuts down that whole hypothalamic pituitary testicular axis that we talk about. Sometimes that can recover. So we often do get referrals for patients who have used steroids in the past, and they just didn't know better. They were young. Mm-hmm. They want to maybe try to get, be healthier, but now they have hypogonadism because they were on steroids. Oh. So we can do some things to try to help support them, see if it can recover. Sometimes it does, sometimes it doesn't. But otherwise there may be some cardiovascular risks, risks of heart disease, heart failure, and it can increase our blood cell volume, essentially concentration, which can increase risk of strokes and things like that. We've certainly heard reports of people dying early who've used steroids from some of these causes. in addition to just some of the, usual annoying side effects like acne and excess hair growth where you don't want it, hair loss where you don't want to lose your hair kind of thing. But sometimes those just happen anyways in guys, as everyone knows, because we do have testosterone, and even in females, they can have some of those issues. And there are a lot of certain absolute side effects in females. A lot of females are getting testosterone. Sometimes they're getting it in these health clinics, very inappropriately, in my opinion. But it certainly improves libido, sex drive in females. It is, indicated in, postmenopausal females with low libido. It's just we don't have great, female specific treatments. And so then you do have to potentially get into compounding stuff. And that's, a little bit of a pain. But a lot of these places put these pellets in females, and then they're getting way too much testosterone, and they're getting hair growth. They're enlarged clitoris, which, maybe they want. And of course, we do that on purpose for our transgender males, so females, biological females, transgender males who see us, we give testosterone, but not above and beyond what male levels should be. We give them male levels of testosterone, and so that they can have some of the facial changes, muscle changes, enlarged clitoris is desired, and losing breast tissue. So those are side effects in females. Of course, in that case, desired side effects, but there are obviously females who are taking anabolic steroids also.
I guess the problem is in supraphysiological dosages, right?
Yeah, but then even out these men's health places that are just giving out what they call TRT, testosterone replacement therapy. Again, if you don't have a cause of hypogonadism that doesn't have an underlying treatable issue and whatever, it's not really testosterone replacement therapy if you're just taking it for no good reason. So while it may not be too dangerous necessarily to take a physiologic dose of testosterone, even if you don't need it, there's still potential side effects. I mean, if you're using a gel, then, you could get it on other people. If you're taking a shot, one, that hurts, I would think, in your muscle. So why do it? And obviously infertility, and it can suppress your own testosterone axis and stuff like that. So I always tell those guys, now this is not anabolic steroids necessarily, but I would absolutely avoid any alleged health clinic where you're paying a bunch of money just for them to give you testosterone. That's a red flag of quackery, as I like to say. And that's unfortunately they're just out trying to market to people and make tons of money and stuff like that. So
yeah, I've seen that many men who are, let's say, over 50 feel like they need TRT.
Right. And the problem is a lot of them, they may have a little bit of what I called that functional low testosterone issue. But that has to do more with oftentimes lifestyle, maybe medications, or maybe they have obesity or sleep apnea. Those are things we can treat. We can treat the underlying issues. And then, of course, there's the whole fatigue thing. We could go down that rabbit hole later. I think you might have some questions on just some other fatigues. But when people start getting into hormones for fatigue that doesn't have a real diagnosis, that's a big concern, because you might miss something. You might have a real other concerning cause of fatigue. And if you just say, I'm going to the men's health clinic and they give you testosterone, maybe it makes you feel better, especially if it's super physiologic and you're just covering up how you feel with a Band-Aid sort of thing. You might be missing a real diagnosis of something that could be really concerning. It's like adrenal fatigue, which I think you might have some questions on that whole thing. People, they use that, they just diagnose everyone. The quacks just diagnose everyone with it. And then it's like, well, what's actually causing the fatigue? The fatigue's real, but it's not adrenal fatigue. Because so same with the testosterone therapies. That happens all the time, it seems like.
So let's say I'm a man over 50. I should exercise, look on my diet, and then consider something like this, not just automatically take TRT to solve my problems, right?
And if you have real concerns, talk to your physician, make sure it's thinking holistically, thinking about everything. And, if you have really suddenly you have low sex drive, low libido, you're not getting morning or overnight erections, maybe your hair growth on your face isn't growing as much anymore, your muscles aren't doing as well anymore, despite, you know, still putting in some effort. That would absolutely warrant a real evaluation into hypogonadism. But then, yeah, don't just take testosterone therapy. You better know why. We get these referrals all the time, because this happens just in general medicine, because people don't dig deep enough. And so we end up getting these referrals. People are on testosterone already, and we have to figure out, well, do they have a hypothalamic pituitary tumor, or did their testicles just fail, which can happen, or whatever. You know, and sometimes we end up diagnosing these big tumors up in their brain that went undiagnosed because they just got put on testosterone, even though they had real, maybe hypogonadism. So,
yeah. And I guess the main problem is when young guys take it in puberty, right? Because that's common.
That's a huge problem. Yeah, I mean, then it's going to shut down their own normal physiology. I mean, that's even worse. Yeah.
Look, let's move to the hypothyroidism and fat loss problematics.
Okay, you said hypothyroidism.
Hypothyroidism. Yes, sorry.
Yeah, so thyroid, I like to tell patients, you know, it's right in here. It's our gland that makes our heat metabolism hormone, thyroid hormones. And it is important for our temperature control, our metabolic rate. You know, so it certainly plays a role in our whole body composition and metabolic health, cardiometabolic health, lipids, sugars, all that stuff. Too much can make us have tremors, heat intolerance, it's hard on our heart. Not enough, we can feel maybe cold intolerance, dry skin, brittle hair, maybe some weight gain. It generally doesn't cause marked, like real obesity, like significant weight gain though. But it's not going to help if you have untreated hypothyroidism. If you're trying to lose weight, it's certainly going to work against you. Most people with hypothyroidism, if they get on even just the basic bioidentical levothyroxine T4 replacement therapy, they're going to do fine. And we would treat their obesity the same as we would treat anybody's obesity. Most of that is going to be targeting the hypothalamic control of energy intake. And we have, you know, medicines, surgeries, obviously primarily lifestyle interventions to help with that. Some people, though, the thyroid makes mostly T4, so people will be interested in, well, what about the T3? Well, the thyroid makes a little bit of T3. T3 is what actually does the work in the nuclei of all of our cells. And so T4 has to be converted to T3 in the body. If you don't have a thyroid, if your thyroid's not working, or from Hashimoto's or other causes. And so some people do tend to maybe feel a little bit better, vaguely sort of prefer in these randomized controlled trials a little additional of the T3, which we have bioidentical T3, and there's also essentially pig sources of combined T4, T3, and they do tend to do a little bit better with their weight in general. So, you know, if I have someone, especially if they're young and otherwise healthy, they don't have a lot of heart or bone risks. So the elderly people, we really try not to use a lot of the T3, just because then it's there, and you know, it's not being regulated by your body as much. But, you know, if there's a young, otherwise healthy person who's being treated for hypothyroidism, they're on T4, everything looks right, the overall dose is a safe, should be reasonable amount, but they still maybe have some fairly thyroid-specific symptoms, struggling with their weight, we'll often add in a little bioidentical T3 and see if they respond to it. You know, and then we just monitor and keep them safe, just like we normally would. There are a few cases where we don't do that, like if they're pregnant, generally if they have thyroid cancer, just because we don't like too many things messing around with what our specific things we're trying to do. But there's obviously personalized nuance there. So, but otherwise, yeah, we still would, you know, personalize their therapy for the severity of their obesity based upon the complications, figure out what's going on with their diet and exercise, sleep, and other medications, maybe optimize the thyroid the best we can, and then, you know, maybe use medications or surgery as indicated as we normally would. But otherwise, it should be, there's no evidence that they do worse per se.
So example, these people should still lose weight when in caloric deficit, but it is harder for them to deliver it, right?
Right. I mean, yeah, you got to make sure the thyroid replacement is optimal. And like I said, some people may need a little bit, you know, they may want to discuss the T3 with their doctor. You know, I don't want to like tell everyone to go out there and do it because that's what the quacks do, and then it drives everyone, kind of up the wall because most people don't need it, but some might, and so it is something to think about. But it's not the answer by any means. It can just help.
Can I affect my hormones via nutrition adjustments? Can I affect my testosterone levels with nutrition? To the point that it affects muscle gains.
Yeah, so the simple answer is yes, in some ways. So there's not much you can do if you're an otherwise pretty darn healthy guy, have good nutrition, good sleep, good exercise, and everything's kind of like status quo. Probably not. There's not anything specific that you can do, but we know that significant caloric reduction, like severe carb restriction, maybe severe fat restriction, and getting really, really lean, like low body fat, that causes one of those functional hypogonadisms, the low testosterone that I was mentioning. So as a wrestler, and I've done some bodybuilding, probably not to the extreme that most real high intensity like natural bodybuilders would do, but in wrestling, certainly back in my day, we all cut weight to make weight. We have like 5% body fat. We're probably all struggling with some low testosterone around that time. But then when you refeed and you get a little bit more body fat, that sort of fat cell hormone, leptin, goes up. It plays a role in the hypothalamus. I don't think we need to get all into the details of all the nitty gritty, but it kind of gets that whole process working again. So that's one way. It's kind of like females, that female athlete triad, when female athletes get really low body fat, they're working out a ton, maybe even overtraining, not eating enough. And they lose their menstrual cycles, and it's bad for their bones. So they have the same sort of thing that happens, and that can happen in guys. And then on the opposite end, overnutrition, poor nutrition, especially with obesity. Like I said, the sleep apnea that can come from obesity, poor sleep, all these things, too much exercise, not any exercise, those things certainly affect it too. So, weight training, exercise, that's all good for, healthy testosterone levels. You don't want to overtrain. You definitely got to get enough good quality sleep. That's hugely important, and kind of an unsung hero. So to some degree, yeah.
Interesting. Thank you. How about peptides and growth hormone in bodybuilding use? I've seen your TikTok videos, so
yeah. So I mean, these peptides that are essentially they're real things. I mean, some of them have been medicines that have been approved, taken off the market for whatever reasons, that actually are act as like growth hormone releasing hormone type triggers, and they're even used for like diagnosis. Like we'll use them to diagnose growth hormone deficiency. But I would not use those if I were other people. You just don't, they're not studied enough. And using growth hormone or those things, if it really is making your growth hormone, and then thus something called insulin-like growth factor 1, the IGF-1, that's growth hormone stimulates the liver to make that. And that like drives a lot of the effects that we want and need in a healthy way, especially when we're growing. And then we do want an appropriate amount when we're older, but too much of that is bad. Acromegaly is growth hormone excess from a pituitary tumor making too much growth hormone, and much higher increased risk cardiovascular disease, sleep apnea, increased risk of some cancers, especially like colon cancer. So you definitely, you should not take hormone medications unless you're truly replacing it and need replacement. Just too many risks. It's also really expensive. So that's a lot of money. I mean, with maybe the hopes of maybe some body composition benefits, but there's no evidence it's a fountain of youth. And if anything, I'd be worried about the adverse effects. And, but on the other hand, if you have hypothalamic pituitary disease and growth hormone deficiency, it is very important to replace, because then it probably has body composition benefits. It definitely has bone benefits. It might have long-term mortality benefits in that case. But if you don't need it, don't take. It's like, why would anybody take a medicine unless there's absolute definite benefit from it? Because there's always risks. But
do you think, is there a reason to adjust training timing during the day from the cortisol changes during the day standpoint?
I would not. No,
Okay.
I don't think so. I don't think so. You got to do what you got to do. You got to do what just is best for you. When do you feel the best? When can you get it in? Absolutely just personalize it based upon how you feel best. If I worked out right before bed, I don't think I would sleep well. I love working out in the morning, which is when your cortisol is actually the highest. Exercise itself makes cortisol go up because it is a stress hormone. We want the appropriate amount of cortisol. But these days, I don't have the time to get up in the morning anymore. So now I end up just working out in the afternoon like I did when I was little, mostly just because that's when the kids are doing their workouts and we're doing it either together or at the same time. So you just got to do what's right for you.
Yeah, so it is better to work out anytime you can.
Yes.
Than not going to work out because cortisol levels.
Don't change what you feel is best because of, cortisol levels being highest in the morning and lowest at night. That I would not absolutely worry about that.
Okay, perfect. How about circadian rhythm eating? Is there any real reason to use this?
Maybe a little bit, but this is going to go back to doing what's right for you. So the different types of time-restricted feeding is kind of what you're getting at. Early morning feeding versus later evening feeding, or the intermittent fasting type stuff. There are plenty of studies now that show that it helps to create an energy deficit and help with weight loss if you like to do it. It's no better really than just straight caloric deficit. So, I tell patients it's a tool to be used. If we want to cut some carbs here, cut some fat there, increase protein, we always want people to eat more whole foods. Maybe we use meal replacement shakes. We can use some intermittent fasting, time-restricted feeding. If we really split some hairs, maybe, according to some recent studies, literally just published in the last month, there was one study that randomized people to getting their calories mostly in the morning versus mostly in the evening. The weight and body composition didn't really change, but the appetite was a little bit worse when they were getting most of the calories in the evening. So, if people feel like they do better when they eat more in the morning and not as much at night, and they feel like their appetite's better, well, that might be helpful. And then there was another study that showed maybe some of the metabolic hormones that play a role in those things like appetite, maybe support why that was the case. But the bottom line was it didn't really matter. And, so again, personalized. It's a tool. I wouldn't stress it so much. I wouldn't do it just because we think it might be beneficial. If it seems right for you, then try it and play with it and work with your, medical team or coaches or whatever to work on it.
Mm-hmm. So adjust it to clients' needs and try to adjust.
And preferences. Yeah. Absolutely. Yep.
Yeah. Sustainability is the key for long-term success, right?
Yeah. And it might be helpful for a lot of people. So if you would have asked me 15 years ago, I would have said, oh my God, that sounds horrible. The studies have proved me wrong. So they're a tool. They're an option. They're not a better option necessarily, but it's a reasonable option to try in some people. I can't do it. I get hangry.
Yeah, of course. How about women, hormones and menstruational cycle and compositional changes in this regard?
So like premenopausal?
Yeah, we can discuss this too, but about menstrual cycle and, training and...
Yeah, there are definitely people out there that try to come up with different types of training regimens for people around their menstrual cycles. But I really think this has got to be a personalized thing. I mean, you just got to do what's right for you. Most females I know just do the same stuff. And they do well, and they go through it. Certainly there are different types of cravings, but all the girls will tell us, right? You might have different types of cravings before, during, after your menstrual cycle, all that stuff. And so, sometimes we have to deal with that and, help with nutrition and things like that. If they feel that they have to change their training regimen, fine. But again, I would leave that up to the absolute individual person and how they feel, because everyone's different.
Yeah, that's the way I do it. I see that just before the menstrual cycle, the girl takes some water in, the body measurements goes up, weight goes up.
Yep.
Of course, she sees it as the end of the world because she's emotional. And sometimes they have cravings.
Yeah, absolutely. You're right. The water, any early, rapid changes in weight, it's always water weight anyways, with all of us, female, male, anybody. I mean, if we go out and have pizza and a bunch of drinks, one, that's not good for our caloric balance, but we didn't just gain a ton of fat from it, right? It's all the sodium. After my last weigh-in for Michigan State at the NCAA tournament, 36 hours later, I was 21 pounds heavier than when I weighed in.
Wow.
Because I also was feeling a little down in the dumps because I didn't do as well as I thought I would. And so I was binge eating and fluid retention, and I just went way, anyways. Yeah.
That's good to know, because I can see people who are really sad because of the weight fluctuations. And I explain also that it's all about average of the week, or take body measurements and don't look at just one weight in. Yeah,
absolutely.
Could we have one more question?
One more, let's do it.
Okay. What are the worst hormonal myths in your profession?
It's got to be adrenal fatigue. I mean, since we mentioned we might bring it up again, it's got to be. I don't know what, it just became this very pervasive thing. We don't need to get into the history of it. But basically, if anybody tells you they think you have adrenal fatigue, you need to go find a real physician, clinician to help you figure out what your fatigue actually is from. If you have real adrenal disease, that's a very serious thing. You can have too much cortisol, that's our stress hormone, that can either be from a pituitary tumor telling your adrenal glands to make too much cortisol, or very rarely you're going to have like a very serious, like other cancer making it, or you could have an adrenal growth making too much cortisol. Those are very serious things that need to be checked. On the other hand, real adrenal insufficiency can either come from hypothalamic pituitary disease or medications, sometimes those functional things we talk about, like with testosterone, or you can have primary adrenal disease. It can be autoimmune, it could be from bleeding, like a hemorrhage. It could be from, like in other parts of the world, more often tuberculosis, infiltrative diseases. And it's very serious, especially if it's your adrenal glands that are being attacked for whatever reason. It's very serious to have that type of adrenal insufficiency. Just kind of this vague fatigue. If someone says adrenal fatigue, you better get checked out for real, because there are lots of causes of fatigue. And if it's your adrenals, you're going to need an endocrinologist like me. If it's other stuff, you need to find out what it is. So fatigue is a very holistic, requiring evaluation. What's going on? Diet, exercise, sleep, which is usually what it is in these cases, by the way. So then you end up paying $500 to the quack, and they give you some sort of supplement while hopefully appropriately helping you with your nutrition and exercise and sleep and stress reduction and that sort of thing, and you feel better. But it's not because of the adrenal pathology in those cases. So that's a huge myth that we just got to keep fighting the best we can so people aren't getting screwed over.
So lifestyle and habits is more important thing than supplements, right?
Yeah. There are no supplements that you should take for cortisol or adrenal stuff. I was just thinking about this today, thinking about making a little meme or something about how, one quack will say, oh, your fatigue is from adrenal fatigue. Here, take this supplement. Or even sometimes they give corticosteroids like hydrocortisone that we actually give people with adrenal insufficiency, which is not good to take if you don't need it. Or they'll say, actually what you need is all your belly fat's from too much cortisol. So then give you a supplement to try to reduce your cortisol. So there's like these two different opposing quackeries that, they're just confusing people.
Sense.
And so if you have one of those things for real, you're going to be seeing somebody like me, and it's a big deal. And they do need to be checked. Anyways, it's a whole thing. It's complicated, but there's some serious issues. So, yeah.
If you could give one advice to our listeners, what would it be from you?
It would be to, really embrace lifestyle optimization the best you can. And it's always personalized. Nutrition, physical activity, exercise, non-exercise activity, sleep, stress reduction. I say that to my patients. I'm like, it's easier said than done. I know. I wish I could magically reduce your stress, but use your resources, do the best you can. And if there's something, that seems wrong, then talk to your real physician about it and try not to get swayed too much into these crazy online, quacks that are trying to sell stuff.
When someone wants to follow your stuff, where can they find it?
So I'll, Facebook, Instagram, Twitter, TikTok at Dr. Karl Nadolsky. And then, as you know, we have our Docs Who Lift podcast these days too, where, we talk about a lot of this stuff. So
I recommend this one. It's a very great podcast, I have to say. Okay. Dr. Nadolsky, thank you very much for your time. I am happy to have you here second time even.
Yeah, thanks for having me.
Have a fine day.
You too. All right.
Bye-bye.
Bye-bye.